Good evening, everyone. Thank you for joining us this evening. I would like to introduce to you Dr. Kathy van Rooyen. She is the Regional Managing Pathologist of our NRL laboratory. Thank you, Dr. Kathy.
Thank you, Yolandi. I'm seeing something strange on my screen. Can you hear me?
Yes, we can hear you, Doctor.
Okay. No, that's fine. It's a privilege to introduce Dr. Nicoline Stein, one of my colleagues. She completed her undergraduate studies at the University of Pretoria, where she obtained her MBCHB degree in 2013. She completed her internship in Pietermaritzburg and her community service in Nelspruit. And during this time, she was quite busy. She obtained a diploma in primary emergency care, as well as a diploma in anesthetics from the Colleges of Medicine of South Africa. She then spent several years doing emergency medicine as well as general practice before returning to the University of Pretoria and Steve Biko Academic Hospital to complete her postgraduate studies in chemical pathology. She obtained both her M.Med and her FC Path in chemical pathology in 2023, after which we were very lucky to have her join AMPATH, and she is currently working at the AMPATH National Reference Laboratory in Pretoria, or Centurion, where she is working in the specialized chemistry department. So we're really looking forward to your talk, Nicoline. Thank you very much.
Thank you very much, Dr. Kathy. Can everyone hear me?
Yes, can hear you, Doctor.
Okay, wonderful. Good evening, and thank you very much for joining us on this cold and rainy night. I hope everyone is cozy and comfortable and you have your beverage of choice available for this next hour that you're going to be spending with us. So today I'll be taking you through a reform in multiple sclerosis diagnosis. Specifically, we're going to be discussing the 2024 McDonald's criteria for the diagnosis of multiple sclerosis. This update actually reflects not just an incremental change, but a whole conceptual shift in how we diagnose multiple sclerosis, particularly in the early stages of the disease. Early and accurate diagnosis is essential for optimizing outcomes in individuals with this disease. Since 1965, diagnostic criteria have guided clinicians in identifying multiple sclerosis. The original criteria, termed the Schumacher criteria, was established in 1965, and this showed the fundamental requirement of demonstrating dissemination of attacks in both space and time, but at the time relied solely on clinical evidence. At that time, advanced imaging techniques such as MRI and lab-based paraclinical tests to supplement clinical assessment, as well as cerebrospinal fluid biomarker results, were either not yet developed or unavailable. Subsequent revisions of the diagnostic criteria incorporated validated advances in both imaging and lab biomarkers, which enabled earlier and much more accurate diagnosis by improving sensitivity without compromising specificity. As the Schumacher criteria evolved through the Poser criteria in 1983 to the widely known McDonald's criteria, which we now use from 2001 onwards, objective paraclinical measures were progressively integrated into every single revision. Key benchmarks included the incorporation of MRI findings into the 2001 McDonald's criteria, and then the 2017 McDonald's criteria updates, which allowed CSF-specific oligoclonal bands to satisfy the dissemination in time criterion for individuals with a typically clinically isolated syndrome and clinical or MRI demonstration of dissemination in space. In 2024, the International Advisory Committee on Clinical Trials in Multiple Sclerosis established the revised McDonald's diagnostic criteria for multiple sclerosis, which we are going to be focusing on tonight. So over the past decade, we've seen major advances in numerous fields, including immunology, neuroimaging, and lab diagnostics, and these have fundamentally changed how we understand the disease process in multiple sclerosis. The 2024 McDonald's criteria aim to provide a single framework for diagnosis across all ages and be applicable to both relapsing and progressive disease, but most importantly, to enable earlier diagnosis. And why is this important? Because multiple sclerosis is a disease where we know time equals brain. So the earlier we treat, the better the long-term outcomes tend to be. One of the biggest challenges we face in early central nervous system disease is that there is significant diagnostic overlap. Early multiple sclerosis can look very similar to other conditions such as neuromyelitis optica spectrum disorders, as well as myelin oligodendrocyte glycoprotein antibody-associated disease, or MOGAD, as well as autoimmune encephalitis and certain CNS infections. And this is really not just an academic issue. These conditions have very different treatments, and misdiagnosis can lead to very harmful therapy choices or delay the correct therapy in patients, leading to significant morbidity and mortality. So the challenge in this disease and most CNS diseases is to diagnose early enough, but still accurately enough. And this balance is exactly what the 2024 criteria are trying to improve. MRI still remains central to the diagnostic criteria, but its role has actually expanded even more. Key updates to the criteria include that diagnosis can now be made based on dissemination in space alone, provided that there are lesions present in at least 4 anatomical locations. The optic nerve has also now been included as a 5th location, and this is clinically very relevant because optic neuritis is often an early presentation, and previously this was underutilized diagnostically. We're also seeing much more advanced imaging use. The central vein sign and paramagnetic rim lesions is an improvement in specificity, where some of the MRI findings might be borderline, and dedicated optic nerve imaging is encouraged for these patients. These improve specificity, especially when the imaging is not 100% positive. MRI is no longer just supportive, it can now be diagnostically sufficient in the right context. Let's have a look at a case just to demonstrate how the criteria has expanded. So a 28-year-old female presents with acute unilateral visual loss, pain on eye movement. She has no prior neurological history, and the MRI brain shows periventricular lesions as well as juxtacortical lesions. No spinal cord lesions are reported. Would you be able to diagnose multiple sclerosis at this point? Under the 2017 criteria, we would need to prove dissemination in space as well as dissemination in time. So in a case like this, it might be prudent to wait for a new lesion, which can eventually lead to much higher morbidity and delay our diagnosis quite significantly in a patient like this. Or we can rely on the cerebrospinal fluid oligoclonal bands to prove dissemination in time. Now, if we apply the 2024 criteria, if this patient has lesions in more than 4 locations, including the optic nerve, which is quite likely on her presentation, multiple sclerosis can be diagnosed without proving dissemination in time. So this just shows that MRI has become significantly more powerful and that the optic nerve inclusion is clinically very critical. We can now diagnose earlier, even at first presentation. So where does the lab fit in with this if MRI is such a powerful tool at the moment? Cerebrospinal fluid biomarkers has always been central to multiple sclerosis diagnosis. Traditionally, oligoclonal bands were the gold standard. CSF-restricted oligoclonal bands have served as the gold standard lab marker of intrathecal humoral immune activation for decades and remains deeply familiar to practicing neurologists. Their value derives from the demonstration of compartmentalized CNS immunoglobulin synthesis of foundational relevance in demyelinating disease and their consistently demonstrated high sensitivity. CSF-restricted oligoclonal bands are present in about 85 to 95% of individuals with clinically definite multiple sclerosis, with meta-analytic estimates of around 88% sensitivity and 92% specificity for multiple sclerosis or clinically isolated syndrome versus controls without inflammation. Although very widely used, traditional CSF oligoclonal bands have limitations in standardization, turnaround time, and interpretation. Oligoclonal band detection requires isoelectric focusing coupled with immunoblotting. And this method is limited to labs with special expertise because it's technically quite complex, it's labor intensive, and it's also very subjective to interlab variability. A key update in the 2024 criteria is the introduction of kappa-free light chains. These represent a quantitative measure of intrathecal antibody production, and importantly, they're now considered to be equivalent to oligoclonal bands in the updated criteria. And why does this matter? It's much faster to obtain these results, they're more objective, it's easier to standardize, and this represents a major step forward for lab medicine. CSF-restricted oligoclonal bands result from intrathecal immunoglobulin synthesis by activated B cells and clonally expanded plasma cells that have migrated across the blood-brain barrier. Within the central nervous system, plasma cells produce both fully assembled immunoglobulins as well as free light chains. During immunoglobulin G synthesis, heavy and light chains are produced independently in the rough endoplasmic reticulum and then assembled to form a complete immunoglobulin molecule, composed of 2 heavy chains and 2 light chains. The assembled immunoglobulin molecules are then transported out of the cell, and light chains are produced in an estimated 20 to 40% excess compared with the heavy chains. So this surplus light chains that are not incorporated into complete immunoglobulin molecules remain unpaired and are secreted as free light chains. Among these, kappa-free light chains are more abundant than the lambda-free light chains and are thus more easily measured. The key takeaway here is that activated plasma cells act as antibody assembly factories, producing both fully assembled immunoglobulins and free light chains. So both of these can be a marker of intrathecal inflammation. Quantitative measurement of free immunoglobulin light chains serves as an objective and a scalable biomarker of intrathecal inflammation and is analogous in significance to oligoclonal IgG detection. Kappa-free light chain measurement, however, uses automated platforms, providing much more rapid quantification and improved interlab standardization compared with the subjective interpretation of oligoclonal band gels. The kappa-free light chain index performs very well diagnostically. It's highly sensitive, even at low levels of intrathecal inflammation. It also predicts conversion risk in very early disease, and it shows about an 87 to 90% agreement with oligoclonal bands. It also now has international expert endorsement. So in practical terms, it's a very robust and a reliable biomarker, and it's been formally integrated into the McDonald's diagnostic criteria. It can't be used as a standalone, but it's very powerful when it's integrated with your MRI as well as your clinical findings in making a definite diagnosis of multiple sclerosis. So let's have a look at where kappa-free light chains can aid us. A 35-year-old patient undergoes MRI for headaches. On the findings, it includes multiple periventricular lesions, no other clinical signs, and the CSF results show a kappa-free light chain index, which is elevated, and oligoclonal bands, which are positive. So in this case, would you observe the patient? Do you diagnose multiple sclerosis? Do you initiate treatment? This is classically a radiologically isolated syndrome. Historically, it would be prudent to either monitor this patient or wait for clinical conversion. Now we know that the kappa-free light chain index predicts a conversion risk. So the higher the levels, the higher the likelihood of developing multiple sclerosis. Kappa-free light chains thus provide us with a risk stratification. So it doesn't have only a diagnostic role, but also gives us prognostic insight. And this allows for closer monitoring and earlier intervention decisions. So beyond its diagnostic role, as I've mentioned, quantitative kappa-free light chain measurements can offer a prognostic value. Higher levels are associated with shorter time to first relapse, as well as more frequent relapses, even in patients who have oligoclonal bands positive as well. So what does this mean clinically? Kappa-free light chains may help us to identify patients with early high disease activity who may benefit from earlier escalation of therapy. So we're moving away from only, is this multiple sclerosis, to how aggressive is this patient's multiple sclerosis, and do we need to intervene earlier and more aggressively? So where the biggest shift happens in the 24 criteria is the removal of the requirement for dissemination in time, if either there's sufficient evidence of space, so multiple lesions on MRI, or if there's sufficient alternative evidence, like high kappa-free light chains present. The impact of this is that 42.7% more patients get diagnosed, and the diagnosis is made around 6 months earlier. This is a major step forward towards earlier treatment and better outcomes without sacrificing the specificity. So this is not about over-diagnosing patients, but about being more sure about our diagnosis and making smarter diagnoses. In practice, it's probably prudent to use both kappa-free light chains and oligoclonal bands where possible. Kappa-free light chains are especially useful when oligoclonal bands aren't available. But if the kappa-free light chains are normal or borderline, and we'll go into what that means, but your clinical suspicion remains high, it is advisable to also still check on oligoclonal bands. It's also important to remember that certain other conditions may also cause an increase in CNS kappa-free light chains, as well as elevated serum-free light chains in a patient who has, for example, a plasma cell dyscrasia or renal impairment can also affect the CSF interpretation. So the bottom line is that these tools together can improve our accuracy and confidence in diagnosis. There's a couple of diagnostic pitfalls that we need to just be aware of, and I have touched on a couple of these. So we can have false positive kappa-free light chains being increased when inflammation isn't due to multiple sclerosis. So then it's often more mildly elevated in other inflammatory conditions, including certain other central nervous system inflammatory conditions, as well as systemic infections and autoimmune encephalitis. We can also have false negatives. So very early multiple sclerosis can be very hard to detect, and intrathecal inflammation may not be established very early in the diagnosis. So kappa-free light chains may still be normal early on, especially very low lesion burden or a very short disease duration. So it's important to not rely on the kappa-free light chains alone to exclude multiple sclerosis. It's important to still use your clinical acumen and use serial MRI on follow-up. It's also very important to not have an over-reliance on a single test. So no test sees the whole picture. Kappa-free light chains, oligoclonal bands, and MRI, as well as clinical features, all have strengths and blind spots. That's why all of these are included in the guidelines for diagnosis. Using only one test can lead to a misclassification. So it's best to use both kappa-free light chains and oligoclonal bands complementarily and not competitively. It's also important to realize that you cannot really use these tests and interpret them without a context. So obviously the clinical story still matters most. An abnormal test does not necessarily equal multiple sclerosis, and a normal test does not necessarily mean that it's not multiple sclerosis. So obviously it's always important to integrate the full clinical radiological as well as the lab picture when evaluating your patients. So let's have a look at a case where kappa-free light chains can assist us or be slightly confusing. So this is a 42-year-old patient who presents with a longitudinally extensive transverse myelitis with severe disability at onset. The MRI shows spinal cord involvement with very few brain lesions, and the CSF shows very mildly elevated kappa-free light chains, but negative oligoclonal bands. So what would be your leading diagnosis in this case? In this case, the features are more suggestive of something like neuromyelitis optica spectrum disorder or MOGAD rather than multiple sclerosis. So if you only relied on the CSF kappa-free light chains, you might be led to the incorrect diagnosis. So it's important to realize that it can still be mildly elevated in other inflammatory diseases. Kappa-free light chains and even oligoclonal bands are not 100% disease specific. So again, very important to interpret along with clinical features, MRI pattern, additional antibody and other testing. So misdiagnosis here could lead to incorrect therapy, worse outcomes, and a delay in the correct treatment and the correct diagnosis. So this is where clinical judgment remains essential. Okay, so you may have heard that I've mentioned CSF kappa-free light chains as a separate entity and kappa-free light chain index. So the kappa-free light chain index is analogous to the IgG index, whereas the CSF kappa-free light chains can be measured as an absolute value as well. And there are certain advantages and disadvantages to both these tests. So advantages to measuring a fixed CSF kappa-free light chain concentration value include obviating the need for concurrent serum testing. So if you need to do the kappa-free light chain index, just as with the IgG index or the oligoclonal bands, you would need to do both serum and CSF taken concurrently. So the advantages of doing the CSF kappa-free light chain standalone is that we obviate the need for serum being taken at the same time. And it's a standardized quantitative measurement. We eliminate the human error that comes along with oligoclonal band interpretation. And it's a reduction in cost and turnaround time compared with standard oligoclonal band testing, as well as a reduction in cost from the CSF kappa index. So just a couple of practical points. We currently offer cerebrospinal fluid-free kappa light chains as absolute values on nephelometry in our lab. We require only a very small CSF volume, and we have reference ranges which is in keeping with the current best literature practice. So it gets measured as milligrams per liter, and we accept a value of less than 0.6 as negative, 0.6 to 0.99 as borderline, and more than 1 or more as positive. So especially in the borderline cases, it would probably be prudent to also do oligoclonal bands or integrate it with all your other diagnostic findings, because it's these borderline cases where it might actually be due to another inflammatory process and not multiple sclerosis. So although an elevated CSF kappa-free light chain concentration can be caused by intrathecal immunoglobulin synthesis, it can also be caused by a passive diffusion from serum in cases where the blood-brain barrier is leaky. So measuring the CSF kappa-free light chain concentration alone cannot differentiate between these two potential sources. So this introduces the risk of false positive elevations in cases of patients with disrupted blood-brain barrier integrity or significantly raised serum-free light chains. So if the value alone, the absolute value of the CSF kappa-free light chains is being interpreted, it's especially important to look at clinical findings, MRI findings, serum kappa-free light chains, and potentially oligoclonal bands. Whereas the kappa-free light chain index, which, as I've mentioned, is analogous to the CSF IgG index, adjusts the CSF kappa-free light chain value by comparing it with both serum kappa-free light chain levels as well as the albumin quotient. The albumin quotient reflects the permeability of the blood CSF barrier. So the CSF kappa-free light chain index accounts for CSF kappa-free light chain concentration, serum kappa-free light chain concentration, estimating how much might actually be entering from the bloodstream, as well as the albumin quotient, which acts as a surrogate marker of blood CSF barrier permeability. Because albumin is not produced within the CNS. So this assessment actually helps to distinguish true antibody production inside the CNS from kappa-free light chain molecules that have passively leaked in from the blood, making it a more accurate marker for MS-related immune activity. The kappa-free light chain index normalizes the CSF value and provides a measurement that more accurately reflects the true intrathecal kappa-free light chain synthesis, which is a key pathologic process in multiple sclerosis. The 2024 McDonald's criteria recommends a kappa-free light chain index cutoff value of 6.1 to denote a positive result. But an article that was published last year actually suggests that there's also a gray zone between levels of 3.5 and 20, where a oligoclonal band should also preferably be done, and only considers an index of over 20 to be definitely positive. So both these CSF kappa tests have their advantages and disadvantages. Measuring the CSF kappa free light chains as an absolute value, you just need to interpret it more within the context of the entire patient, whereas our kappa free light chain index, which is would be approximately double the cost, and you would have to include serum as well at the same time as your CSF, kind of helps us to make provision for possible leakage from the blood into the CSF. So both of them are very good markers to utilize to aid as a surrogate marker for dissemination in time. So from a lab perspective, there's a couple of pre-analytical considerations that always need to be need to be considered. So if the kappa-free light chain index or oligoclonal bands are ordered, a paired serum and CSF sample needs to be collected at the same time. It's very important to try and avoid a traumatic lumbar puncture because blood contamination can actually also falsely increase the CSF kappa-free light chains. The CSF needs to be promptly processed and stored at 2 to 8 degrees. And it's very helpful for us to know what the clinical context and the MRI findings are along with the request, because this aids us in interpreting the results much more accurately if we know what the whole picture is. So potential pitfalls and how we try to avoid them. So if the patient has a raised serum kappa-free light chain, such as a patient with a plasma cell dyscrasia or monoclonal gammopathy, chronic inflammation or renal impairment, this can affect the absolute value of your CSF kappa-free light chains, in which case you just need to take that into consideration, or preferably order the CSF kappa-free light chain index, or order oligoclonal bands along with your CSF kappa. Then if we have borderline results, it's prudent to either repeat the lumbar puncture or use oligoclonal bands as well if your clinical suspicion remains high. It's important to remember that other inflammatory diseases can also have a mild elevation in kappa-free light chains, and also even in oligoclonal bands. Sometimes it's also possible to have discordant results, where, for example, you'll have positive oligoclonal bands, but the kappa-free light chain levels will be normal, or vice versa. And this can be especially confusing in early disease, but there may also be a slight assay variability or technical factors. And it's also important to remember that it will be more likely that the kappa-free light chains will be standardized and harmonized across different labs than the oligoclonal bands. So it's very useful to try and use both tests together when possible. So we love to communicate with clinicians and understand the clinical question behind the request. So if the results are confusing or you need someone to help you to interpret tests, especially if you just take the absolute CSF kappa, please give us a call. We're happy to discuss. If we have a better understanding of the clinical context and other findings, we can provide better interpretive comments for you, and we can highlight limitations and potential confounders. It's important to be aware of assay variability between different labs, and please be reassured that we use validated and standardized methods in our lab. We also participate in external quality assessment and try to keep up with evolving evidence as we go. So let's have a look at a patient here with early multiple sclerosis, but negative oligoclonal bands. So a 24-year-old female with numbness and weakness in the left leg, episode of optic neuritis 3 months ago, no prior neurological history. She has multiple periventricular lesions and just the cortical lesions, as well as a lesion in her spinal cord on MRI findings, but her oligoclonal bands are negative. However, the kappa-free light chain index is elevated. So can we diagnose multiple sclerosis even when the oligoclonal bands are negative? And the answer is yes. So in this case, the other evidence is supportive of multiple sclerosis. So according to the 2024 diagnostic criteria, the kappa-free light chains also can be independently used as an objective proof of intrathecal antibody production. So it's important to realize that up to 10 to 20% of especially very early multiple sclerosis patients may have negative oligoclonal bands. And the kappa-free light chains detects intrathecal antibody production with a very high sensitivity. This supports much earlier diagnosis and treatment decisions, but it also always, as mentioned a couple of times now, needs to be interpreted in context with the clinical and MRI findings. So just to summarize, the 2024 criteria enable a much earlier diagnosis. The MRI criteria has been significantly expanded. Kappa-free light chains are a key new biomarker, and we now have a much more flexible and a practical framework. Ultimately, this is about diagnosing multiple sclerosis much sooner and more accurately. However, there's obviously always future directions. The field is always growing, and this is quite a new biomarker. So this has actually now transformed the way that multiple sclerosis can be diagnosed. But the next step will be to maximize the potential and broaden the impact of this new biomarker. So one of the first steps would be standardization and harmonization. And this is to establish a global consensus on cutoffs, assays, and reporting formats. At the moment, there is quite a bit of literature on this, and there are certain cutoffs that have been adopted, and cutoffs that have been recommended by the 2024 McDonald's criteria. But since it's still a relatively new biomarker, the assays and the reporting formats for gray zones and definite positivity may still be adjusted in the future. It's important to also improve assay standardization as well as commutability across platforms, so that if a patient follows up at different labs, you can still be able to compare the results accurately. It's also something that needs to be looked at to develop age-adjusted and population-specific reference ranges. So beyond the diagnosis of multiple sclerosis, as I've mentioned, it has a prognostic role, and it can also have a role in monitoring the disease potentially. So kappa-free light chains need to be validated as a prognostic biomarker for long-term outcomes. Currently, it can help us to predict earlier disease onset, but because it hasn't been used that long, there hasn't been as many studies to actually show whether higher levels initially can give us an idea of what long-term outcomes might be. We can also explore its role in predicting conversion in radiological isolated syndrome and clinically isolated syndrome, and also investigate the utility in monitoring disease activity and treatment response, which is a field which is quite exciting, where this might definitely be able to assist us in knowing whether we are treating aggressively enough, and to be sure that the patient is getting the right treatment at the right time. Then there's also a number of other new CSF and blood biomarkers on the horizon that have not yet been integrated into guidelines as yet, and are not really widely available as yet. It's more in research, but in future, it's likely that kappa-free light chains can be combined with other CSF and blood biomarkers, such as neurofilament light chains and cytokines. And eventually, what is likely to happen is that a multi-biomarker panel, as well as AI-driven models, will be used and utilizable to improve the accuracy. And this is a definite move toward precision diagnostics. Then there's also a definite room for expanding the clinical application of CSF kappa-free light chains. So the role of kappa-free light chains in other neurological diseases with intrathecal inflammation needs to still be evaluated, and see what levels or what values might be predictive or be considered positive in these different diseases, where it might just be seen as a gray zone in multiple sclerosis. And it might also be used in pediatrics, older adults, and diverse populations. So the aim of the 2024 criteria is for the guidelines to be applicable to all age groups and across populations. And kappa-free light chains can definitely be used in all populations at this point, but age-adjusted and population-specific reference ranges might need to be developed in the future. And this will be strengthened by real-world evidence from multi-center studies. And then it's very important that these tests become more available, more affordable worldwide, so that kappa-free light chains can be clinically integrated into pathways and guidelines, and clinicians and labs can offer these confidently and have a confident interpretation. So we need to bring all of these tools together to make the best diagnosis. So if we have the right clinical context, the right biomarkers, and interpret everything together, the diagnosis can be made much earlier, and the patients can ultimately have much better outcomes if we initiate their treatment soon enough. Okay, thank you very much for your attention. I'd be happy to take any questions. And if you would like to rate the CPD activity, there's a very short survey that you can access just by scanning the QR code.
Thank you very much, Dr. Nicoline. I will leave the QR code for a moment so people can scan it if they want to. We have a few questions. Someone was asking, how often will a kappa-free light chain be done for patients in terms of disease progression and monitoring?
So there's not specific guidelines as yet for the use of the kappa-free light chains in monitoring disease activity or monitoring treatment, but that is definitely something that is currently being researched. So it is definitely something that in future would definitely be useful to aid in deciding when to escalate treatment or to de-escalate treatment for certain patients.
Thank you, Doctor. And then another question. Would medical aids pay for both OCBs and CSF kappa-free light chains? Also, this requires an lumbar puncture, so can't do OCBs, and if negative, do CSF kappa-free light chains?
So, I suppose it would be medical aid dependent, whether they would be willing to pay for both, but you might be able to motivate, especially because it now forms part of the 2024 McDonald's criteria. So for both CSF kappa-free light chains as well as oligoclonal bands, you do require a lumbar puncture. So for oligoclonal bands, you require the CSF as well as the serum to be taken at the same time. For the CSF kappa-free light chains, you can either order an absolute value or the CSF kappa index, in which case you also require serum. So for both tests, you require CSF, but as mentioned, it is most likely prudent to order both tests together. Whether the medical aids will be willing to pay for both we would need to see in future whether that is something that they'd be generalized able to pay for both. But initially it might require some motivation.
Thank you, Doctor. There's another question. Is this also used nationwide in the government labs?
So as far as I know, it is not being offered in public sector at all at the moment. And as far as I know, AMPATH is the only lab that currently is offering CSF kappa free light chains. It's definitely not being offered in NHLS as yet. But because it is now part of the guidelines, hopefully it will also soon be available in the public sector.
Thank you, Doctor. Then the next question is, how do you determine a progression of MS?
How do you determine progression? So yes. The 2024 McDonald's criteria is more guidelines for diagnosis. So you can use your MRI findings, you can use your clinical findings, and you can also use your biomarkers to diagnose. Then to predict progression, your kappa-free light chains being a quantitative assay, if it's significantly higher or a very high kappa-free light chain level, would indicate a higher likelihood of progression or higher likelihood of a higher disease burden in these patients. But very specific cutoffs have not yet been established for this. And then other indications of a progression in disease would be clinical findings, new onset of neurological symptoms, or worsening neurological symptoms, as well as new or increased findings on MRI.
Thank you, Doctor. I'm not sure if you would know this on the top of your head, but someone was asking for the cost of the CSF kappa free light chain. So if you don't know it, then I will get back to them on email. I'm not sure if you know on the top of your head.
Yeah, so it's around about 500 Rand for the CSF kappa absolute value, and that's on cash. And comparatively to the oligoclonal bands, which is around it's around 800 to 900 Rand. So it's about half the price of doing the oligoclonal bands, but that is just for the absolute value. If you do the CSF kappa index, it'll probably be around about the same amount. So around about 900 to 1,000.
Thank you very much, Doctor. I'm just looking through the comments to see if there are any more questions. Okay, it doesn't look like there are any other questions. So that will be it then. Thank you, Dr. Nicoline, for your time, and thank you everybody for joining us. I hope you all have a wonderful evening. Bye-bye.
Thank you very much.
Thank you. Bye.